Well, thank you very much. It's one of the challenges of doing the postprandial because everybody is kind of like not sure if they should wake up or not. When I was asked to do this initially, it was the organizers wanted me to do a couple programs, and I thought that one of them, she said, was going to be a workshop, and the other was going to be a keynote speaker, thinking that those would be two completely different groups of people. So in fact, I've got the same talk tomorrow that I'm doing today. So rather than develop that type 3 diabetes, Alzheimer's that we're so accustomed to, what I'm going to do is I'm going to actually put some stuff together that'll feed off of the presentation that was done this morning. But I have a nice overview of some of type 2 diabetes, where we should be in the next 50 years. And so I'll present some of that information tomorrow instead of duplicating this. Here's my speaker disclosures. What's important to realize is, what's the number one cause of death in patients with diabetes? Cardiovascular. It's not their blood sugar. I'm an endocrinologist, but I tell you, I frankly don't think glucose really matters. We get so fixated. You heard about what's the magic number to say you have diabetes or not. I don't care if you got diabetes or not. I want to know, do you have insulin resistance? Because insulin resistance is what's going to derive your disease. And you can see in America, we have 1 million people that have a heart attack every single year. 1 million. And 1/3 of those incur in people who already had a heart attack. And I teach my house staff, you can put in a new bypass machine, a new bypass in the heart, but if you don't change the oil in the engine, it's going to explode again. So we have to recognize that as being very, very important. We use the traditional modifiable risk factors that we talk about, such as smoking, lowering blood pressure, treating lipids, and all of that. And I think that's important because those have shown beneficial effect. But what I'm going to show you today is we need to go beyond modifiable risk factors. We need to look at our genes. We need to look at inflammatory markers. We need to look at other very important parameters that we do when we treat this. And then when we identify it, we need to treat aggressively. So here are the standard modifiable risk factors that we have. Certainly we have this epidemic of obesity. We already know that. And then I call it what I call the foot and fork disorder. Okay? Patients say, well, why am I having a problem? I said, you suffer from too much fork and not enough foot. Okay? As you heard earlier, we've got to increase our exercise activity. Alcohol intake is important, but modest alcohol consumption in most people is actually beneficial. But I'll show you some data that alcohol in some subgroups is actually harmful. Smoking, clearly a major issue that we should do. Psychosocial factors. Most people forget that stress, you heard earlier in the program, stress is a major modifier of that. Then you got hypertension, diabetes. But you notice I put in parentheses insulin resistance, because that's what I think is important, is identifying, do you have insulin resistance? And I'm going to show you, it's a very easy way you can define whether you have insulin resistance or not. And then, of course, dyslipidemia is a major factor as well. So here's medical nutritional therapy. We obviously should encourage weight loss and stuff like that. What I will show tomorrow as part of this the 50 years from now, I actually just published a paper on medical nutritional recommendations. It's about time we get it right. And I will point out to you what drove the massive obesity that set off in America. It all started in 1980. So just kind of put into mind 1980, and I'll show you what happened before 1980 and shortly after 1980 that caused this epidemic that we're dealing with right now. Obviously, you have to address carbohydrates, protein, fats. You heard the talk on protein. Bottom line is calories. It doesn't matter what it is. It's calories that drives obesity. It's not whether you eat too much protein, too much carbohydrate, too much fat. Limit alcohol, obviously, and smoking cessation. I put this in here. I'm a beer can collector. I collect cans all over the world. And this is a 1-gallon can that I have from Chicago. It was made in Chicago in the 1960s. And I just use it as a reminder because my doctor says I can only have 1 can of beer a day. So he didn't define the size of the can, but I just did I followed orders. And, of course, Rauchen Verboten for the German back there. I put this in here just to show you the psychological component. Huge psych component to cardiovascular disease. So, people can just say all your other risk factors can be perfectly fine, but you can have enormous stressful factors which drive a lot of disease. Now, here's the insulin resistance. This is what you want to know. If you look at people with cardiovascular disease, 80 to 90% of them have insulin resistance. And most of them don't even know they have it. It's common with arteriosclerotic vascular disease. Very few patients have have cardiovascular disease but don't demonstrate insulin resistance. It's about only 10%. And the goal, and there's been these parameters we've tried to look at, the triglyceride HDL ratio, at least in Caucasians. If it's over 3.5, that would suggest you might have insulin resistance. In Hispanics, it's about 3. African American, it's 2. That's kind of a nice little marker, but it's still not perfect. Look at the A1C. I never look at the A1C to determine whether somebody has diabetes or insulin resistance. I mean, I don't think the new guidelines saying that you can make a diagnosis of diabetes on an A1C is correct. And we've done studies to show that they're 50% right, 50% wrong when you do the standard test. The most important test is an oral glucose tolerance test. Give yourself 75 grams of glucose and measure your 1 hour and 2 hour glucose. You don't need to do the 3, but the 1 hour and 2 hour. If your 1 hour is greater than 125 and your 2 hours greater than 120, you have insulin resistance. You know, she gave the nice talk show on the 80-80. I never heard the 80-80 because you use picomolar, and we always do weird things in America. We use different micromolars or whatever, nanomolar. But anyway, if you do this test, it's very simple. 75 grams, 125, 120, you have insulin resistance. You are at increased risk of cardiovascular disease. And I ask yourself, do you know if you are IR or not? If you don't know, check it out. All right, so I've talked about those traditional modifiable risk factors, but we need to go beyond that. We need to look into genetics. You heard the talk about, well, you know, the Japanese moved to America. Is that really the genes? No, it's probably not the genes. It's the lifestyle. But there are certain genes that the Japanese have that mandate a certain nutritional recommendation versus those who come from other countries. Non-invasive testing, we'll talk briefly about that. Inflammatory biomarkers. It's important to look at some inflammatory biomarkers because you can have all the traditional, you can have none of the modifiable risk factors and still have significant cardiovascular disease because those don't pick up the inflammatory markers. And then I'm not going to spend much time on it, but looking for heart failure. If you've never done your NT-proBNP, you might want to do it. You might be surprised. 10% of patients with diabetes have elevated NT-proBNPs. That can be very germane when you start talking about treatment with DPP-4 inhibitors like Onglyza or Nacina, because that could actually make their heart failure worse. And then obstructive sleep apnea. So here's how I describe atherosclerosis. I call it primary, secondary, and tertiary. I know we do primary and secondary, okay, but to me it's more important than that. Primary means you look for disease, you can't find it. You've looked everywhere. You can't find it. Secondary means you look for disease, you find it. You go, ooh, I didn't expect that. Then you ask yourself, has that person ever had an event? And the answer is no. So that person to me is really secondary. And then tertiary is somebody who's already had an event. So here's kind of the summary of the 4 things: the lifestyle, genetics, non-inflation, and drug therapy. So you can't get any more personal than your genes. You know, I always tell people when it's very important that you always do a good job picking your parents. That's always very vital to survival. Because as you've heard earlier, if your parents weren't very good, behaved themselves, then you're in trouble. And it's grounded in our genetics. And so what I'm going to do is I'm going to go through some key genetic testing that every one of you in this room should have done. And it's part of what I've been trying to push with the American Heart and that to do, because everybody's focused on LDL. They think if they get the LDL down to minus 30, there'll be no more heart disease. That's not true. There's a lot of other risk factors besides LDL. So here are some of those markers. ApoE genotype. Do you guys know what your ApoE genotype is? If you don't, you should. Good. You know. KIF6. How many of you have even heard of KIF6? Okay. Very important marker because it's going to tell you which statin is going to work in you and which one's not going to work in you. 9p21, heart attack gene. Factor V Leiden. Factor V is much more relevant and germane for women because of the fact that because of the clotting factors with estrogens. And then the LPA aspirin genotype. We used to recommend that this was being measured in everybody, but it's expensive. It's not terribly expensive, but it's important that there's only certain subsets of patients that you really need to measure that. So let's start off. Here's ApoE. All right, we have 3 alleles, 2, 3, and 4. So you could be at 2-2, 2-3, 3-3, 3-4. 25% of the population is ApoE4. 20% is 3-4, and 5% is 4-4. Why is that important? There's actually a pretty strong link with Alzheimer's disease. and the ApoE isotype. Whether they're causality or whether they're true related, it's not completely clear, but there's no question that knowing your ApoE genotype is going to impact on some long-standing diseases, like you said, heart disease and that. But here's what's more important, your nutritional recommendations. If you have ApoE4, then a low-fat diet is very effective, okay? And there I showed you the 20 and 5% that have the disease. But here, look at what happens with low-fat diet. Actually, I have to correct myself. A low-fat diet and actually an ApoE4 makes it worse. I'm sorry, makes it better. But the other thing that's really, really important is that what does fish oil do? Everybody thinks, oh, fish oil is really good for you. Well, it's not really good for you if you're ApoE4. And the last thing is what about alcohol consumption? If you have ApoE4, the recommendation is to limit your alcohol to 1 glass of wine per week or 1 beer per week. And I have a lot of colleagues who I'm not going to measure my ApoE because you're not going to tell me that I can't have my glass of wine every night. There's no way in hell you're going to tell me that, Dr. Lardinois. So a lot of the recommendations that we do for medical nutritional therapy are really driven by your ApoE isoform. I don't see anybody discussing that when we talk about management of patients with heart disease. Here's the KIF6. Again, since we're running a little behind, but this is a very important transport protein. And the reason it's important is because when you look at your KIF6, there's either a KIF6 variant or a KIF6 non-variant. 60% of Caucasians have the variant, 40% non-variant. It's a little different with other ethnicities, but not a whole lot different. But if you have KIF6 non-variant, so you don't have the variant, this is a study with pravastatin. Even though you got comparable LDL reductions, there was no benefit of cardiovascular disease in the patients that didn't have the variant. And it was the same with the atorvastatin study, the PROVE-IT TIMI 22. It did not show benefit despite identical reductions in LDL cholesterol. So if you're somebody that's going to go on a statin, and your doctor says, well, your cholesterol is high, you need to go on a statin, if he doesn't know what your KIF6 is, which I'm sure 99% don't know, then you better prescribe only simvastatin and rosuvastatin because the other two are not going to work. The other thing I find, so this is the KIF6 testing that you can do. If you're a carrier, it doesn't matter. All statins work very effectively. They've had good studies with atorvastatin and pravastatin with the variant. KIF6 non-carriers, they are at increased risk, and I strongly recommend that you only use simvastatin or rosuvastatin. Here's another one I like. I see doctors all the time. Well, I gave my female patient Lipitor. Well, is there any data? I love the cardiologists say, well, we have to have scientific, evidence-based medicine, Dr. Lardinois, to show it. Okay, well, where's the study that shows that Lipitor reduces heart disease in women? Oh, we don't have any. Well, then how are you recommending this if there's no study? I thought it lowers cholesterol. Well, again, there's no study that showed that. The big hype in this study was the fact that the paper came out, the news media came out and said it reduced heart disease. Nobody said, oh, by the way, only in men. 9p21 is a very interesting, it's called a KIF, 9p21. It modulates this ankyrin regulatory gene, which turns out to be very important because it controls a lot of the proteins in your vascular wall. So these are associated with aneurysms, one of the biggest concerns here. How many of you, you all have had somebody 35, 40, 45 that's working with you in your office and drops dead of a cerebral aneurysm? It happens. And probably a lot of those patients had 9p21 that we didn't recognize. And if you look at it, only 27% of the population, 27% of us in this room actually have the non-carrier. Most of us, including myself, fall into the 9p21 heterozygous, and then there's this small group of homozygous. And this becomes important because it increases your risk of heart attack and aneurysms. So if you have a 9p21 homozygous, you're going to want to look very carefully for aneurysms, do abdominal thing. You might even want to consider doing some type of measurement upstairs. And this just shows you the genotype reporting. For the sake of time, we won't get into it. Here's factor V Leiden. It's actually described after the place in Holland where this was discovered in 1994. And it's not a trivial number. It's about 5% in the United States. And in women, it becomes particularly important because of the fact that you increase thrombosis. And even so, we put women on estrogen hormone replacement therapy. The studies, even the Women's Health Study, most people don't know this, but the WHI, the women that had the factor V Leiden had much higher incidence of a deep vein thrombosis. So you just have to be aware of that. This is that LPA gene variant. And again, for the sake of time, where I would measure this is you measure the LP little a. You guys are familiar with LP little a? I hope so. Lipoprotein associated, LP small a. Very important lipoprotein. You'll have a lot of patients with hypercholesterolemia who their LDLs don't look that bad, but then you look at their LPA and it's off the chart. So you should measure this test routinely. Most, especially with familial hypercholesterolemia, all the big buzz floating around with FH now, they're really strongly recommending measuring LP little a. And part of the reason, too, is that we had very few therapies that could lower LP little a. The only one we really had was niacin. And, that's not well tolerated. But the PCSK9s do a remarkable benefit on lowering LPPLA, too. So I would not recommend you do the genotype unless the LP little a is greater than 30. Where it becomes important, though, particularly in primary prevention, is aspirin therapy. There's always this bugaboo about, do I give the aspirin to prevent the heart attack, but then I get a GI bleed, and the patient, you didn't have a heart attack, but you died of, hemorrhage. And that's, when you're dead, you're dead. It's not very gratifying. So what we try to do is look at these patients, and if they have the elevated LP little a and they have the variant, then those patients you want to put on aspirin. If they don't have this variant for primary prevention, I don't recommend aspirin. Now, when I say that's primary, if it's secondary, they've already had an event, that's a whole different story. People say, well, you don't recommend aspirin for heart disease? No, I said for preventing heart disease, I don't recommend aspirin unless you have the LPA variant. And this is just to give you a summary of the LPA gene variant. There's been a lot of studies that have been done with this. The Women's Health Study did it. There was a big study, the ERIC study in Europe that looked at it. And the bottom line is if your LP little a is elevated and you have never had an event, go on aspirin. If your LPA variant, you don't have the variant, then I do not recommend aspirin as primary prevention. Here's some other genes you can do, but for the sake of time, we won't get into them. But the second one there is the statin myopathy gene. If people say, well, my muscles ache, I can tell you this whole bugaboo of myopathy with statins is so challenging because 50% of the patients on the placebo also complain of aches and pains. And it's interesting, it's more of a problem in the United States than other countries. So it's sort of like I think our media has driven this to where, you took a statin? Did your leg fall off? Yeah, you have a claim. Here's haptoglobin. You all know about haptoglobin, right? We all have, that's how we carry our red cells. Well, I can tell you there's a lot more about haptoglobin that you need to appreciate, and that is that your haptoglobin phenotype is going to dictate your risk of atherosclerosis. And again, because we're running a little bit behind, I'm not going to get into great detail on this, but I can make all these slides available for you if you like. I thought maybe they would want us to bring in a handout or something, but I could be happy to. But you have you have three different haptoglobins: 1,1, 1,2, and 2,2, and they're fairly equally spread out. It's about 40. I think it's 30, 40. Maybe 2 is a little higher incidence, and that becomes particularly germane because a lot of the work with HAP2 has actually come out of Israel, looking at risk factors. And here's why it's important. If you have haptoglobin 2,2, you have a substantial increased risk of atherosclerosis. Now remember, what does haptoglobin do? It helps remove iron from the system. The phenotypes, the way the phenotypes are, the 2,2 does a slower job of getting rid of that iron. So it increases your risk of atherosclerosis. You can see here's the breakdown of the HAP1, HAP2, and HAP2 there. Now, where it becomes even more exciting is that pre-haptoglobin 2 is a hormone called zonulin. How many of you heard of zonulin? Okay. Another thing I think that you need to think about in this realm of atherosclerosis and autoimmune diseases, because we have this tight junction. And we knew there were these very tight junctions in the gut. Remember, why do you have those tight junctions? Because you don't want all that crap to leak out, and cause all that inflammation. So you have these nice tight junctions that keep everything nestled in. Well, it turns out that the tight junction is zonulin, okay? And zonulin is a fascinating hormone, and it's associated with a lot of neurological diseases. And the other thing that's, so you can see zonulin itself has its own activity through EGFR, or it can be cleaved to the haptoglobin scavenger. And these become important because of the fact that it drives autoimmune disease. And as you can see, here's all these autoimmune diseases that are associated with zonulin. And it's called sweet 16, you know, I guess sweet 16, this is chromosome 16. I wouldn't necessarily consider this chromosome very sweet, because if you look at all the things on there, they're pretty nasty. All right, moving on to some non-invasive testing. I think it's important that you get a look for disease. A non-expensive way is to do a CIMT. You can look for carotid intimal medial thickness. You can do coronary calcium scores. A lot of cardiologists still kind of against coronary calcium scores. And I said, well, why? I said, if I do a coronary calcium score and it's high, I know that person's got disease. They should be treated. If I do a coronary calcium score and it's 0, there's not much data that'll show you for the next 10 years giving them a statin is going to make any difference. And if we're talking about cost effectiveness, we say, oh, these tests are expensive. You get this test at almost any place for $99. It's cash, but $99 to let you know if you need to take a statin for the rest of your life, I think it would be worth it. Ankle brachial index, and then the abdominal ultrasound, particularly the abdominal ultrasound if you're 9B21. Here's the CIMT. I don't know if you routinely do this or look for this, but it's pretty easy to detect subclinical atherosclerosis. It's an independent predictor, and you can read the rest as well as I can. And anytime you do a Framingham study, when you do the risk stratification, then you add the CIMT, it changes the risk stratification. What they find is probably 10-15% actually go down in their risk stratification, but more likely about 20 to 25% go up. From the Framingham risk factor. I'll give you, for example, for myself, my Framingham risk score was 8%. And that was mostly driven by age, you know, because the longer you live, the more likely you're going to get disease. But my CIMT put me at the 25th percentile, along with my coronary calcium score. So even though I had none of the traditional modifiable risk factors, I clearly had disease, and I would have never picked it up had I just relied on the Framingham risk score. And this is the thing that you see here. Here's the CIMT, and it says if the plaque is greater than 1.2 millimeters, then you have disease. You show this, and of course, because we're in Texas, Houston, we have a problem. We have a problem that we need to address. Here's the coronary calcium score. Again, a pretty easy test to do. Takes about 15 minutes, and it does give you a lot of stratification of disease. And also it helps, I find, when patients know, they're in the know, they appreciate, boy, this is not good, they'll be actually more attentive to what we try to get them to do. But here's the scores. If you're lucky enough to have a score less than 10 or less than 11, your risk of having an event in the next 10 years is pretty low. And it goes up accordingly based on that. Here are the associations that you see, but this is where I say with the statins. I mean, if you look at the ACH-AHA guidelines, it basically said once you reach, I think it's 65.8 in men and 71.4 in women, all of us should be on statins, just based on their criteria. Well, we know that's ridiculous. So this helps us to stratify those patients better. Inflammatory markers that you should look at, I think are very important, is HSCRP. I'm not so convinced that it's great a marker as some people think. Richter certainly has his view, but then again, he gets like 2 cents every time the test is run, so there's an economic thing. And it's interesting talking about the economics that has driven some of our healthcare. Lipoprotein-associated phospholipase A2, LPPLA2 is a very important marker that you should do as well. And most labs will do these for you. They're available. They've got Boston Heart, you got Cleveland Clinic, you got Quest Diagnostics. There's a lot of places. Mygentic is another company that can do these tests for you. Checking the albumin in your urine is very important. Also looking at F2 isoprostanes, myeloperoxidase, and homocysteine. Hear a little bit about homocysteine this morning. Here's HSCRP. Again, Mendelian-wise, there does not seem to be an association. I think the association really is driven by the metabolic syndrome, or which I really don't like. I don't like the term metabolic syndrome. I like insulin resistance syndrome. Partly I have to do that because I trained with Jerry Reven in 1980 when we put this model together. And when I say metabolic syndrome, he tosses me out of the lab. And part of the reason I think it's important is because they say you have to have 3 of these criteria to meet the metabolic syndrome. Well, we've had hundreds of patients that had insulin resistance that didn't meet the 3 of these criteria. So, but as you can see, if you use this model, each time you add one of those, your HSCRP goes up. So I don't know that HSCRP is that helpful. I think the plaque 2, LPPLA2, though, however, is very important, because look at these levels here. Even if you have a normal blood pressure, I mean, look at that. What's that? I think it's less than 115 or and you have an elevated LPPLA level, you have a substantial increased risk of stroke. And it's interesting. My father had a stroke when he was 74, and he had bad hypertension, and I figured that's why he had his stroke. But maybe it wasn't hypertension. Maybe it was his LPPLA2, because my LPPLA2 is elevated, and maybe I got it from my dad. Like I said, I didn't do a good job of picking my parents. Here's the kidney. You guys measure albumin in the urine? Sure hope so for a patient with diabetes. And my recommendation is take the word microalbumin out of your vocabulary. It's a very bad term. It was described 30 years ago looking for macroalbumin. But you know, it's interesting, I asked residents, what's microalbumin? Oh, that means the molecule is small. They actually think that it defines the size of the albumin. Okay? So I just say, is there albumin in the urine or not? Period. And do an albumin to creatinine ratio. Now, here's the definition. Again, I like to, because you're outside the box like me. You don't agree with probably 90% of what the guidelines say. But they say less than 30 is normal albuminuria. Less than 30. Well, where did they come up with that 30? They were looking at studies in kidney disease, progression to renal failure. Had nothing to do with cardiovascular disease. If you really want to reduce cardiovascular disease, you have to get that albumin to creatinine ratio less than 7.5 in women and less than 4 in men. And here's the thing that they don't ever talk about, or very little is talked about. You've got to adjust it to muscle mass. Remember, men have larger muscle masses. So you've got to adjust that number. That's why men is 4 and women are 7.5. If you use the same number for everybody, you're underestimating the degree of albuminuria in men. And I think this is a very powerful cardiovascular risk factor and one that we must address more and more. But interestingly, you hear all these studies, these drugs lowered albumin but didn't reduce heart disease. Well, they didn't use the albumin as a marker, an endpoint. You can't say just because you lowered something but you didn't use it as an endpoint that there's not causality. The problem is, at least in the United States, the FDA will not let you use albumin in the urine as an endpoint, which I think is ridiculous, but that's what we have. So here I say 7.5 in women, 4 in men. F2 isoprostanes, a very important thing that's produced. And again, for the sake of time, I won't go into great detail on this except one important thing. What do you think happens when you exercise? What happens to F2 isoprostane levels? They go up. And this is an inflammatory marker. So you're out there telling your patients, you need to get off your butt and start doing some hiking or something, and you're saying, oh geez, is that really, maybe that's not a good thing that I'm recommending. Well, it turns out for the 99.9% of the population, exercise, it does go up transiently, but then it comes back down. But there is one group of people that it goes up and stays up. Okay? I've asked this question at many conferences, and I will ask anybody, how many marathon runners do you know that suffer from longevity? They all die of premature cardiovascular disease. And I have no doubt that that's a major contributing component. I had one of the guys who used to make my slides for him in the old days, the 35 millimeter slides. Well, he dropped dead about 2 years ago. He's like 57, but he was always talking about, man, I'm going this marathon, I'm going to that marathon, and I'm doing this marathon. Well, he's not doing any marathons anymore. Myeloperoxidase. I call it the Joker. Joker's wild because about 2 people out of every deck have an elevated myeloperoxidase. And why is myeloperoxidase important? Because it drives inflammation. Myeloperoxidase actually interacts with hydrogen peroxide to form bleach. Bleach. Now, why would you want to make bleach in your body? Well, actually you do. You think it's kind of crazy. Why would I want to make bleach? Well, because if you had a bad parasite or you had a bad pathogen, you'd want to kill that rascal. You'd want to bleach the hell out of him. But the problem is, if you make too much myeloperoxidase, it actually interferes with your HDL. And it takes your HDL, which was functional, to a dysfunctional state. And you can see right here how myeloperoxidase converts our anti-inflammatory HDL to a pro-inflammatory. This is part of the bugaboo we have with HDL, just looking at HDL. It's hard to look at HDL and assess atherosclerosis, although studies clearly show the higher your HDL is, the lower your risk of cardiovascular disease, but there's going to be those subsets of patients that have inflammation or stuff like that where the HDL is not going to help you. And that's where HDL efflux or that is becoming very important. Here's homocysteine. A lot of debate. They said they've done studies, randomized controlled trials, we lowered homocysteine, it didn't reduce heart disease. Well, you went from 14 to 11, okay? I don't know what that means, okay? I'm saying, but you take people over 15, people with homocysteine levels over 15, they have substantially increased cardiovascular disease, and you need to think about that in the management of those patients. I do treat patients with homocysteine levels over 15. And then the NT-proBNP. If you've never had it done, get it checked. Maybe it's one of those things you don't want to know, but it's very helpful. And I think in my diabetes patients, it does help because it'll identify patients with, they've actually done studies where they just measured NT-proBNP and then they did echoes on everybody. If your NT-proBNP was less than 125, there was no evidence you had any left ventricular dysfunction. So, I see cardiologists always ordering echoes. Why? What do echoes really tell you? I mean, my joke is there's only one contraindication to an echo. You know what that is? No heart, okay? If you don't have a heart, you don't need to do an echo, okay? But we spend a lot of money on tests that really don't tell us a whole lot of stuff, or even treadmills. How much does treadmills really help us? Ask the guy for Meet the Press. He had his treadmill 2 weeks beforehand and said he's just perfectly fine. He drops dead right, what was his name? I can't think of it right offhand, but Meet the Press fella. Here's vitamin D. A lot of controversy with vitamin D, but I think if you're really severely vitamin D deficient, I think that replacing it can be very beneficial in reducing cardiovascular events. But the studies are still kind of weak, and a lot of them, they supplement, and the level's already normal. But I will tell you in diabetes patients, if your vitamin D level is less than 10 in both type 1 and type 2s, you have a substantial increased all-cause mortality, period. So, we get into bugaboo between 20 and 30, what's normal, or 30 and 40. But clearly, if you're less than 10, you have substantial increased all-cause mortality. And obstructive sleep apnea, don't forget about this as being a very important thing as well. You'll be surprised how many patients you'll discover that have obstructive sleep apnea, and you really didn't have any good signals. And I'd say probably 70-80% of the patients with type 2 diabetes probably have some degree of obstructive sleep apnea. And so it's always harder to manage them. One of the remarkable things I've seen is patients who go on CPAP and who really said they really didn't, don't feel like they're sleeping any better or doing anything different than before, and noticed that their blood pressures were down about 10 millimeters of mercury. And if you think about it, if you have a lot of apneic events in the middle of the night, it's certainly going to disrupt your circadian rhythm and increase your risk. So here's a nice cartoon. It says, I'm going to hibernate in another cave. You have sleep apnea and you're snoring. It kept me up all last year. So, this poor bear here says, he wants to get some sleep. All right, well, wrapping it up, no question atherosclerosis is the number one cause of death in the world. As I said, I'm an endocrinologist, but I really don't fret on the glucoses because the glucose, there's no data, in my opinion, that shows tight glucose control actually saves lives. If anything, it's more harmful. There can be subsets that might be effectively, but hypoglycemia is not a pleasant event, and we should try to avoid that at all costs and focus on other things. The current standard of care we have is good, but we got to do much better. I mean, you look at all the studies with statins. 70% residual risk still. Well, what does that tell us? That there's a lot of things that we're not identifying that are important. Genetics play a huge role. You should get those basic genetic markers. And if you want, I can provide you contact or information to get those. I have no proprietary to any of those companies. It's just that those are the people, when we set up our risk reduction clinic, those are the people we reached out to get information. And then again, when disease is found, treat the root cause. And I do think it's time for a paradigm shift. I think we have to get away from the traditional modifiable risk factors and move to a more disease platform. We need to look for disease. When we find disease, we need to treat it. I'll stop there, and I'll be happy to answer any questions.
Thank you, Dr. Lardinois. Do we have any questions? Ladies and gentlemen, there we go.
Yes, it was a wonderful presentation, Dr. Lardinois, but one thing I was thinking about, because I'm a professor in medical school and I teach students, and to do the paradigm shift, always a student asks us that how costly it will be. And that's a big dilemma for us, that this isolation of these risk factors, like genetic one, you were talking about ApoE and all those. Now, not everywhere in the world they are capable of doing. I'm not talking about America. I'm talking about third world countries and all. And what answer we should give to next generation in that way?
Well, I mean, the dollars always drive everything.
Yeah.
And it was interesting, at lunch I was talking to, and I can't believe this, that Medicare does not cover the varicella vaccine, that you have to pay like $200 to get the varicella. But if you get the shingles, they'll be more than happy to spend $20,000 with your hospitalization and all that. The genetic testing, these tests I told you about, cost about $1,000. Well, I can tell you my exercise treadmill with my cardiologist was $1,100, and that didn't tell me anything. I mean, I went 16 minutes. The only reason we stopped was because the nurses were upset because most people only last 7 or 8 minutes, and I was interfering with their coffee break. Okay, so if we're gonna, we have to proportion our money more intelligently. We have to get into a society of prevention instead of intervention, and until we can convince, but the cardiologists, all those people that are doing the interventions, they're not about to give up. It's true in the third world countries, I think so. But a lot of these tests too. If you guys ever heard of Boston Heart, these tests. Not all of these tests, but some of these tests they will do for you. And the one thing about Boston Heart is that when you get the blood drawn and it's sent to the lab, they bill your insurance, okay? But if their insurance doesn't pay it, they don't come back to you. They don't come back to you.
So with the same thing in the American, because I teach in American medical schools, I mean, curriculum of American stuff, and the preventive medicine is all missing. Mm-hmm. In the curriculum of American medical schools, the preventive medicine is all missing, So until unless you guys start from the mainland, it cannot percolate anywhere.
Right. Totally agree.
Thank you.
It's true that prevention medicine is not everywhere. I was interested by you said marathoner die at early age, don't finish. I think we have this myth that an athlete is healthy, not professional athlete. A professional athlete put their body at the exhaustion level. And you see that in football, you see that. And no, they're not, by definition, healthy. But we can say that moderate exercise is good for your health. Yeah. Definitively, moderate exercise is a huge impact on that. And I will follow my question to you. The problem with heart disease, when epidemiological studies stand, if we don't die from cancer, we'll probably die from heart disease. It's by definition the finish of a life. It's a natural life and we can go against that. At which time you decide that heart disease, if you take off all the statistics, the people that died for heart disease, at which time you consider that it's early death caused by heart disease compared to a natural cause phenomenon?
Well, that's a very important question, because even to me, if you argue, I'm a gerontologist as well, and you look at Alzheimer's disease, is really Alzheimer's a disease, or is it just a normal aging process? I mean, at age 80, it starts to go up like a rocket. Well, is that all of a sudden just something? Did Mother Nature design the brain to function more than 80 years? I don't think so.